Hi everyone, welcome back to Path Demystified. I'm Dr. Shubhika Sachdeva and today we are going to talk about a very interesting, simple yet a very complex topic, obesity. So I'll be dealing with this particular topic in three parts. So today we are only going to concentrate on the definition, the assessment of obesity, risk factors in etiology, and a very interesting aspect, that is the pathogenesis. In subsequent videos, we are going to talk about the complications associated with obesity and finally childhood obesity and the genetics behind obesity. Okay, so let's start with our today's video, that is the pathogenesis, definition, types and etiology of obesity. So, how do we define obesity? Well, in very simple terms, obesity is defined as accumulation of adipose tissue that is sufficient enough to cause impairment of health. Making this very simple sentence a bit more complicated, WHO defined obesity as a condition in which there is increase in the percentage body fat to such an extent that will impair health and well-being. And because of its alarming prevalence, WHO declared obesity as a global epidemic. So moving ahead with assessment of obesity. Obesity can be assessed in three ways: the indirect methods, direct methods and criterion methods. Indirect methods include assessment of body mass index, abdominal circumference and skin fold thickness. These methods are very accurate and precise, and therefore these methods are used to predict and evaluate the disease risk in epidemiological studies. Direct method assessed body fluid distribution and body cell mass, whereas your criterion methods assess the bone density, fat mass by using dual energy X-rays or CT and MRI. Both direct and in criterion methods are very less commonly used to assess obesity. So we are only going to concentrate and talk about body mass index and abdominal circumference in detail in subsequent slides. So let's talk about body mass index. I'm sure everyone have heard about BMI being used so commonly, right? So what is the concept behind it? What is BMI? BMI is defined as body mass, that is weight in kgs divided by square of body height in meters. To put it in more simpler words, it is the person's weight with respect to his height. So BMI is just an indicator of person's total body fat. It gives you a descriptive index of the body's habitus, and it helps us to categorize people ranging from both lean to obese. So it becomes simpler for us to monitor the treatment in obesity. So WHO gives a range of 18.5 to 24.9 as a normal BMI. Less than 18 is underweight. More than 24.9, that is ranging from 25 to 29.9, is pre-obese or overweight, and beyond 30 we have divided obesity into three classes based on the severity, that is 30 to 34.5 will be obese class 1, BMI ranging from 35 to 39.9 will be obesity class 2, and BMI more than 40 will be obese class 3. So the second very important indirect method for assessment of obesity is abdominal circumference. Abdominal circumference is a practical measure of central or visceral obesity, and it is defined as accumulation of fat in the trunk and abdominal cavity, that is in the mesentery and around the viscera. And this type of accumulation of fat is associated with much higher risk of diseases like diabetes, metabolic syndrome, cardiovascular diseases, cancer, and more mortality associated with obesity. So, having understood how to assess obesity, let's move ahead and see the types of obesity. Broadly, there are 6 types of obesity, and we are going to talk about each one of them. First one is inactivity obesity. Inactivity, as the name suggests, it is associated with sedentary lifestyle. There is accumulation of fat in neck, chest, stomach, arms, waist, etc. And this type of obesity strongly predisposes the person to complications like type 2 diabetes, hypertension, sleep problems. Second is your genetic metabolic obesity. This is seen in people who have heavy intake of alcohol or carbonated soft drinks, and there is accumulation of fat in the middle part of the body and all around the waist. The third is anxiety obesity. This type of obesity is also called as obesity due to nervous stomach, and it is most commonly seen in women because of depression or anxiety, which leads to overeating. Then fourth is your venous obesity. This type of obesity is genetically inherited and there is accumulation of fat in lower abdomen. Then fifth is your gluten obesity. This is most commonly associated with hormonal imbalance. So when will you have hormonal imbalance? Hormonal imbalance is most commonly observed in adolescent girls or menopausal women, and there is accumulation of fat in buttocks, hips, thigh, ankles, etc. Then the last one is arthrogenic obesity. It is also called as central obesity, and there is accumulation of fat in abdomen and back. And this, as we discussed earlier, central obesity has a very high risk of cardiovascular diseases. Moving ahead with risk factors associated with obesity. Well, we need to understand one thing, that we don't get fat only by eating junk food. Obesity is caused by a very complex interaction between environmental factors such as food patterns, food composition, temperature, lack of physical activity, acquirement of certain infections, all coupled with family history or genetic factors like mutations. These all interact with each other to promote or impair your molecular processes, thereby leading to obesity and further complications associated with it. So, obesity can be caused by neuroendocrine factors like hypothalamic obesity, obesity associated with hypothyroidism, Cushing's disease, PCOD, pregnancy, or excessive use of oral contraceptives. Certain drugs such as antipsychotics, antidepressants, anti-epileptics, serotonin antagonist can also cause obesity, and other factors such as sedentary lifestyle, high fat diet, consumption of excessive sweetened beverages, binge eating can also cause obesity. So, finally coming on to the pathogenesis of obesity. See, obesity is a disorder of energy homeostasis. What happens in a normal individual, there is a balance between energy intake and energy expenditure, which is very finely regulated by neuronal and hormonal mechanisms, so that the body weight is maintained in a narrow range. When there is an imbalance between energy intake and energy expenditure, that leads to accumulation of fat and obesity. Before actually diving into how this all happens, let's understand the components of the neurohormonal mechanisms that regulate the energy balance. And there are three components. The first is the afferent system. The second is the central processing system, and the third is the efferent system. The afferent system or the peripheral system consists of signals which are generated from various sites, and the most important of them are leptin secreted from the adipocytes, ghrelin secreted from the parietal cells of the stomach, insulin secreted from the beta cells of the pancreas, peptide YY secreted from intestine, L cells of the intestine. The central processing system resides in the hypothalamus and the arcuate nucleus of the hypothalamus. And this consists of two sets of neurons. A pair of first order neurons which consist of pro-opiomelanocortin and cocaine and amphetamine regulated transcript, that is the POMC cart set of neurons, And the second, neurons containing neuropeptide Y, NPY, and agouti related peptide, that is the NPY and AGRP set of neurons. The second order neurons consist of pair of neurons associated with melanocortin receptors and Y1 and Y5 receptors. I know this is a little overwhelming, but we'll make it simpler in subsequent slides. The efferent system consists of signals generated from these second order neurons, and these is divided into two pathways, the anabolic circuits and the catabolic circuits, and these control the food intake and the energy expenditure. So these are the three components of the neurohormonal mechanisms that regulate the energy balance in our body, and in subsequent slide we'll see how does that happen. So, having understood the components, let us understand how these components interact with each other and regulate the energy expenditure and the energy balance of our body. So, when you have adequate energy stores, that is, your stomach is full, you have a very good nutrient intake. What will happen? Adipose tissue will secrete leptin. Leptin will go and act on the POMC cart set of neurons, thereby cleaving POMC from this pair. When this POMC is cleaved, it will go and give rise to alpha melanocyte stimulating hormone. This alpha MSH will go and activate your melanocortin 3 and 4 receptors, that is, it will set a stimulus for second order neurons. As this will happen, these second order neurons will give rise to brain derived neuronotropic factor, thyroid releasing hormone, corticotrophin releasing hormone, and these hormones will go and initiate a catabolic pathway, thereby they will increase your energy expenditure, decrease your food intake. So your POMC and CART set of neurons are increasing your energy expenditure, they are decreasing your food intake, therefore they are called as brake pedals for appetite. So they are decreasing your appetite, they are putting a pause on your appetite, so they are called as brake pedals for your appetite. So now on the contrary, when you are fasting, your nutrient intake is less, your energy stores are less, what will happen? Stomach will release a hormone called as ghrelin. This ghrelin will go and act on the NPY and the AGRP set of neurons, thereby cleaving NPY from this pair. As NPY is cleaved, this will go and give signals to the second order neurons, that is the Y1 and Y5 receptors. This Y1 and Y5 receptors will release melanin concentrating hormone and orexin. These MCH and orexin will in turn make sure that your energy expenditure is less and your food intake is more. They will initiate an anabolic pathway, and since they are urging you to eat more, they'll call as these set of neurons are called as gas pedals for appetite. So, having understood how the mechanism works, let us in a little bit more detail understand the signals generated from the afferent pathway. So, the very first signal that we saw was from adipose tissue. So, we have two kinds of adipose tissue in our body, white adipose tissue and a brown adipose tissue. White adipose tissue consists of proteohormones which regulate the body fat mass, and the most important of these hormones are leptin and adiponectin. The brown adipose tissue is the good adipose tissue. It is found abundantly in newborns, and it has a very unique property of non-shivering thermogenesis. So coming on to the very first hormone and a very important hormone secreted by adipocytes, that is leptin. Leptin secretion directly depends upon your body's BMI and your body fat stores. As seen earlier, leptin helps in regulating food intake as well as it helps in regulating the energy expenditure. How? We have seen earlier, when you have adequate amount of adipose tissue in your body, there will be increased secretion of leptin, which will stimulate the POMC cart set of neurons, thereby decreasing the food intake and increasing the energy expenditure. On the contrary, when you have inadequate adipose tissue or body fat stores in your body, there will be decreased secretion of leptin, stimulation of NPY AGRP neurons, and thereby increase of your food intake and decrease in energy expenditure. Leptin also has a very important role and a very interesting role in controlling the thermogenesis, that is your heat production. The hypothalamic signals increase the norepinephrine by stimulating the sympathetic nerve endings in your adipose tissue, thereby controlling the heat production by catabolic effects. A second very important hormone secreted by adipose tissue is adiponectin. Adiponectin is also called as a fat burning molecule. Why? Because this stimulates fatty acid oxidation in skeletal muscles and it reduces the fatty acid levels. Adiponectin also decreases the glucose production in liver and increases the insulin sensitivity. It is anti-inflammatory, it is anti-arthrogenic, it is anti-proliferative, as well as it is cardioprotective. And since it has so much of positive effects and it is protecting you from the negative effects, it is also called as the guardian angel against obesity. But sadly, adiponectin levels are very low in obese individuals as compared to lean individuals, and therefore such people are more exposed to insulin resistance, type 2 diabetics, and diseases like non-alcoholic fatty liver disease. So let us understand what happens in obese people with leptin and adiponectin. So when you have excess of fatty acids, these fatty acids will cross the blood-brain barrier and reach the hypothalamus, where they'll be sensed by microglial cells. These microglial cells, in response to these excessive fatty acids, will release certain inflammatory factors. These inflammatory factors will cause hypothalamic neurons to become resistant to leptin, thereby blunting its anti-adipocytic signals. Now, what happens to adiponectin? Adiponectin will go and bind to adipo R1 receptor or adipo R2 receptor based on the location. R1 are present in skeletal muscle and brain, and R2 are seen in liver and brain. So when this adiponectin will bind to these receptors, it will go and activate cyclin CAMP dependent protein kinase A. Upon activation of this, it will lead to phosphorylation as well as inactivation of acetyl-CoA carboxylase. This acetyl-CoA carboxylase is a very important enzyme for fatty acid synthesis. Now, when this is inactivated, fatty acid will not be synthesized. Along with that, there is already fatty acid oxidation going on in skeletal muscle, as we know that adiponectin is a fat burning molecule. And because of these two mechanisms, the fatty acid levels will be decreased when you have abundant of adiponectin in your serum levels. So, having talked about signals from the adipose tissue, let's move ahead with afferent signals that we saw were generated from the gut hormones. So, gut hormones act as short-term meal initiators and terminators. And the very first hormone that we saw was ghrelin. Ghrelin is secreted from the parietal cells of the stomach, and it is the only gut hormone that is known to increase food intake. That is, it has an orexogenic effect. It will increase your calorie intake. And we saw that how does it do that. Normally levels of ghrelin will rise just before meals and it will fall 1 to 2 hours after meal. But what happens in obese people? In obese people, this drop of the levels is attenuated. It happens at very frequent intervals. The second set of hormones that we saw were peptide YY and GLP. These are secreted from endocrine cells of the ileum and colon, right? So the levels of peptide YY and GLP-1 are lower during fasting and they increase shortly after food intake. Therefore, they have an anorexogenic effect. Both these hormones, as we saw earlier, act centrally through NPY and AGRP set of neurons. And very interesting fact, GLP agonists are used in treatment of obesity and type 2 diabetes because of their anorexogenic effects. What is anorexogenic effect? It decreases its food intake and enhances the glucose dependent insulin secretion. So that's about it for the pathogenesis of obesity. I know it was a little bit complicated, so please go back and hear it once more. I'm sure you will be able to understand. So thank you very much. This was it for this video. I'll see you next time with complications of obesity and a small questionnaire pertaining to this video. Bye bye and take care.